Okie dokie.
All right, sounds
Welcome
good. Keep
to
checking.
part two, guys, of our Human AI podcast. And make sure you've watched part one if you haven't. Yeah, we're going to talk about GI pathologies. Well, to be honest, we finished GI pathologies, so we're going to continue talking about gastrointestinal motility and a bit of UTIs. So, yeah, without further ado, let's get on with it. So, Grog, we've left off when we were talking a bit about some different diagnoses and diseases and all of that. So let's talk a bit about cystitis, please.
All right, jumping into part two of our Human AI podcast vibe, let's dive straight into cystitis. So, cystitis is inflammation of the bladder, usually caused by a bacterial infection, like E. coli, hitching a ride from the urethra. You get symptoms like burning when you pee, frequent urges to go, cloudy or bloody urine, and sometimes lower abdominal pain. It's more common in women because of shorter urethras, but guys can get it too. Risk factors include things like not drinking enough water, wiping back to front, or even frequent sex, hence the term honeymoon cystitis. Diagnosis usually involves a urine test to spot bacteria or white blood cells. Treatment straightforward. Antibiotics like nitrofurantoin or trimethoprim sulfamethoxazole for a few days, plus drinking tons of water to flush things out. If it keeps coming back, docs might look for underlying issues like bladder stones or, in rare cases, something more serious like bladder cancer. Prevention's key. Stay hydrated, pee after sex, and keep good hygiene.
Okay. And what about urinalysis? When do we use urinalysis?
Urinalysis is a go-to test when you suspect cystitis or other urinary issues. Docs use it to check for signs of infection, like bacteria, white blood cells, or red blood cells in your urine, which point to inflammation or irritation in the bladder. It's usually ordered if you've got symptoms like burning while peeing, frequent urges, or cloudy urine. The test can also spot other stuff, like high glucose for diabetes or protein for kidney issues, so it's a broad screening tool. You might do a dipstick test in the office for quick results, or send a sample to a lab for a full culture to identify the exact bacteria and pick the right antibiotic. It's especially useful for confirming cystitis before starting treatment, or if symptoms keep coming back, to rule out complications. Want me to break down how urinalysis works, or what specific results mean?
Yeah, sure.
All right, let's dive into urinalysis. It's a test that analyzes your urine to detect infections like cystitis or other health issues. You pee into a sterile cup, and the sample gets checked in a few ways. A dipstick test is the quick when strips dipped in the urine change color to show things like white blood cells, sign of infection, red blood cells, possible inflammation or stones, or nitrites, bacteria like E. coli produce these. A lab culture can take a day or two and identifies the exact bacteria causing the infection, plus tests which antibiotics will work best. They also check pH, protein, or glucose levels to spot other problems like kidney issues or diabetes. For cystitis, key findings are high white blood cells, bacteria, or blood in the urine. If results are normal but symptoms persist, it might trigger further tests like imaging for...
So what about leukocyte esterase? And how do bacteria reduce nitrates to nitrites?
Nice, diving deeper. Leukocyte esterase is an enzyme released by white blood cells, and it shows up in a urinalysis dipstick test when there's infection or inflammation, like in cystitis. If the dipstick flags leukocyte esterase, it means your body's fighting something in the urinary tract, often bacteria. It's a quick clue for doctors, but they'll usually confirm with the urine culture for accuracy. Now, on bacteria reducing nitrates to nitrites. Certain bacteria, like E. coli, which is a common culprit in UTIs, have enzymes called nitrate reductases. These bugs take nitrates naturally present in urine from your diet and convert them to nitrites as part of their metabolism. This happens when urine sits in the bladder for a while, giving bacteria time to do their thing. A positive nitrite test on a dipstick screams bacterial infection, but it's not foolproof. Some bacteria don't reduce nitrates, and fresh urine might not show nitrites yet. That's why leukocyte esterase and nitrite tests are often used together for a clearer picture. Want me to explain more about interpreting these tests or something else?
Yeah, tell us more about it, for sure. And also tell us about urine specimens and like midstream urine and all of this.
All right, let's keep the podcast rolling and dig deeper into your analysis, focusing on leukocyte esterase, nitrites, and urine specimens like midstream urine. First, let's expand on leukocyte esterase and nitrites. Leukocyte esterase, like I mentioned, is a marker of white blood cells in the urine, signaling inflammation or infection. It's super sensitive on a dipstick test, but not super specific. Things like vaginal contamination or even kidney issues can cause a positive result. That's why it's paired with the nitrite test. Nitrites show up when bacteria like E. coli reduce nitrates in urine to nitrites, but this needs time, usually a few hours in the bladder, so a morning urine sample is best for detection. If both tests are positive, it's a strong hint of a bacterial UTI, like cystitis. If only leukocyte esterase is positive, it might mean inflammation without infection, like from stones or irritation. If only nitrites are positive, it's rare but could point to a specific bacterial issue. A full urine culture confirms the diagnosis by growing the bacteria and checking antibiotic sensitivity, especially if symptoms are tricky or recurrent. Now, onto urine specimens and midstream urine. The type of urine sample matters a ton for accurate urinalysis. A midstream clean catch urine is the gold standard for UTI testing. You start peeing, stop, then collect the middle part of the stream in a sterile cup. This skips the first bit of urine, which might pick up bacteria or cells from the skin or urethra, reducing false positives. To do it right, you clean the genital area with wipes to avoid contamination. Women especially need to wipe front to back. Another method is first void urine, FVUR. Often used for STD tests, where you collect the initial stream, or elderly patients, a catheterized sample might be taken directly from the bladder, or in rare cases, a suprapubic aspiration needled through the abdomen for super clean samples. Contaminated samples, like from porclia, leukocyte esterase, or nitrites. The lab checks the sample under a microscope for white blood cells. More than 10 per high power field suggests infection, and bacteria, then cultures it to confirm. Dipstick results are quick but less reliable than cultures. So if symptoms scream UTI but the dipstick's negative, docs will still send it to the lab. Anything else you want to zoom in on? Like how labs culture urine or specific pitfalls in urine collection?
So with midstream urine, can you explain to me the etymology of midstream and how does it relate to boric acid and how does it prevent cell degradation and overgrowth of organisms?
All right, let's dive into this for the podcast and unpack the etymology of midstream urine, its connection to boric acid, and how boric acid prevents cell degradation and organism overgrowth. First, the etymology of midstream. The term comes from English, where mid means middle, and stream refers to a flow, originally of water like a river. In medical context, midstream urine, coined around the early 20th century, describes the middle portion of the urine flow during urination. The idea is that the initial stream might carry bacteria or debris from the urethra or skin, while the midstream is cleaner, better reflecting what's in the bladder. It's rooted in the concept of avoiding contamination, like taking water from the middle of a stream, rather than the murky edges. Now, how does this tie to boric acid? Midstream urine is collected in sterile containers, sometimes with preservatives like boric acid to keep the sample stable until it's tested. Boric acid, a weak acid derived from boron, has been used as a preservative since the late 19th century, first in food and later in medical labs. It works by creating an acidic environment that slows bacterial growth without killing the pathogens you want to detect. When you collect midstream urine, boric acid in the container helps prevent overgrowth of contaminating bacteria or false positives from non-pathogenic organisms. If urine sits too long without a preservative, bacteria can multiply rapidly within 4 hours at room temperature, leading to inaccurate culture results. Boric acid keeps bacterial counts stable for up to 24 hours, similar to refrigeration, which is great for samples sent to distant labs. As for cell degradation, boric acid also helps preserve white blood cells in the urine, though to a lesser extent. White blood cells, key for spotting inflammation like in cystitis, break down quickly in urine, especially if it's not processed right away. Boric acid slows this degradation. Tests can more accurately detect pyuria, white cells in urine. It's not perfect. High boric acid concentrations can sometimes inhibit pathogens like E. coli, which could skew results. But at the right dose, usually around 20 grams per liter, it's bacteriostatic, meaning it pauses from bacterial overgrowth and preserving cells for better diagnosis. Want me to dive deeper into any part, like how boric acid's used in labs or other urine preservation methods?
Well, tell me about suprapubic aspirate and catheter urine. What are these?
All right, let's keep the podcast vibe going and dive into suprapubic aspirate and catheter urine, what they are, and how they fit into testing for things like cystitis. First, suprapubic aspirate. This is a way to collect urine directly from the bladder using a needle. A doctor numbs the lower abdomen just above the pubic bone and inserts a thin needle through the skin into the bladder to draw out urine. It's super clean because it bypasses the urethra, avoiding any bacteria or debris from the skin or genital area. It's rarely used for routine UTI diagnosis like cystitis due to its invasiveness, but comes into play for specific cases like infants, elderly patients with unclear symptoms, or when contamination is a big concern.
Okay. Okay. Let's jump to another topic. Yeah. So, this is just a bit about the motility of the GI tract and kind of understanding the general structure. So can we talk a bit about the sphincters? We have the upper esophageal with the lower esophageal. We have the pyloric, the ileocecal, and the anal sphincter. So we have a lot of sphincters, and I wonder what's the strategic position of them, you know? Why are they strategically placed there? Strategically kind of implies a conscious, something unconscious doing it, but you know, why evolution put them there? I think you didn't hear. I'll ask you again. I was just asking why we have all of the sphincters we have in the GI, where we have them. Why did evolution put them there?
Got it. Sorry for the mix-up. Let's talk about the sphincters in the gastrointestinal GI tract. These are basically muscular rings that act like gatekeepers, controlling the flow of food, liquids, and waste to keep digestion orderly. Evolution shaped them to optimize digestion, absorption, and waste elimination while preventing backflow or leaks. In the GI tract, you've got a few key sphincters. First, the upper esophageal sphincter, at the top of the esophagus, stops food or acid from creeping back into your throat and keeps air out of the digestive system. The lower esophageal sphincter, at the stomach's entrance, holds stomach contents in to prevent acid reflux and only opens to let food pass. The pyloric sphincter, between the stomach and small intestine, regulates how fast partially digested food moves into the duodenum, ensuring proper mixing and digestion. The ileocecal sphincter, or valve, connects the small intestine to the large intestine, slowing the flow so nutrients get absorbed and keeping colon bacteria from backtracking. Finally, the internal and external anal sphincters control poop release. The internal one's involuntary, and the external one's under your control for, well, timing things right. Why did evolution put them there? It's about efficiency and survival. Without sphincters, you'd have chaos. Food could rush through too fast, missing nutrient absorption, or backflow could cause infections or damage, like bacteria from the colon hitting the small intestine. They also protect against leaks. Nobody wants involuntary pooping, and help separate digestion stages, so each part of the gut can do its job, like the stomach's acid bath or the small intestine's nutrient grab. Early vertebrates probably developed these as digestion got more complex, and they stuck around because they gave our ancestors an edge in processing food safely and effectively. Any part of this you want to zoom in on, like a specific sphincter, or why evolution favored this setup?
I see. Okay. And okay, let me ask you a bit about the layers of the gastrointestinal wall now. So we have 4 layers. We have the serosa, the muscularis externa, the submucosa, the mucosa, we have the lumen, and I want to kind of understand them. We have also connective tissue.
All right, let's break down the layers of the gastrointestinal GI wall. You're spot on that there are 4 main layers, and they work together to handle digestion, absorption, and movement. I'll walk through each one, including the lumen and the role of connective tissue, to keep it clear. The lumen isn't a layer, it's the hollow space inside the GI tract where food, liquids, and waste travel. Think of it as the pipeline where digestion happens. Starting from the outermost layer, the serosa, or adventitia in some GI parts, is a thin, protective coating, usually made of connective tissue and a layer of mesothelial cells. It's like the gut's outer skin, anchoring the GI tract to surrounding structures via connective tissue and reducing friction as organs move. Next is the muscularis externa, the muscle layer that drives peristalsis, those wave-like contractions that push food along. It's got 2 sublayers of smooth muscle, an inner circular layer and an outer longitudinal layer. Together, they mix and propel contents through the lumen. In places like the stomach, there's even an extra muscle layer for churning. The submucosa is a thick layer of connective tissue, packed with blood vessels, lymphatics, and nerves, like the submucosal plexus, part of the gut's mini brain. It's the support network, delivering nutrients to the gut wall and helping coordinate secretions and movements. It's also where you find glands in some regions, like the duodenum. Closest to the lumen is the mucosa, the innermost layer, which does the heavy lifting for digestion and absorption. It's got 3 parts. The epithelium, facing the lumen, where absorption and secretion happen. The lamina propria, connective tissue with immune cells to fight off bugs. And the muscularis mucosae, a thin muscle layer for...
Maybe it's my fault. In general, dude, for the next 100 questions, I want you to be as effective and as efficient as possible and talk to me with the least amount of words, okay? To give me the answer. Okay, let's go forward a bit. And so with the muscularis externa, we have an outer longitudinal layer of smooth muscle and an inner circular layer. We have the myenteric nerve plexus. Can you explain to me why it is the case? It's very arbitrary to me. Can you make it less abstract, please?
Got it. I'll keep it tight and clear. Muscularis externa has 2 smooth muscle layers, outer longitudinal and inner circular. Longitudinal shortens the gut tube, circular squeezes it. Together, they create peristalsis, pushing food through the lumen like squeezing toothpaste. The myenteric nerve plexus, sandwiched between them, is a network of neurons controlling these contractions. It's not arbitrary. Evolution picked this setup because it's efficient. Longitudinal and circular muscles work in sync for smooth, directional movement. The plexus acts like a local brain, coordinating muscle action without constant brain input. so digestion hums along autonomously. It's there to keep food moving one way, prevent clogs, and maximize nutrient absorption. Want more on how the plexus talks to muscles?
No, that's good. Okay. And then we have also talk to me a bit about the mucosa. So we have a lamina propria. What is this lamina propria?
The lamina propria is a thin layer of connective tissue in the mucosa, sitting under the epithelium and above the muscularis mucosae. It's packed with blood vessels, lymphatics, and immune cells like lymphocytes. It supports the epithelium, delivers nutrients, and fights pathogens entering the gut. Think of it as the mucosa's backbone, keeping the inner lining functional and protected. Need more on its immune role or structure?
That's okay. Okay.
All right.
So
Yup.
can we talk a bit about cholecystokinin and motilin?
Cholecystokinin, CCK, and motilin are gut hormones regulating digestion. CCK, released by the small intestine when fats or proteins hit, signals the gallbladder to squeeze bile and the pancreas to secrete digestive enzymes. It also slows stomach emptying to optimize nutrient absorption. Motilin, made in the small intestine, kicks in during fasting, triggering migrating motor complexes, sweeping contractions that clear residual food and bacteria from the small intestine to prevent overgrowth. Think CCK as the digestion coordinator and motilin as the gut janitor. Want specifics on their release or effects?
So it decreases gastric emptying and increases pancreatic secretion, CCK. How does the name relate to the function?
Cholecystokinin, CCK, slows gastric emptying and boosts pancreatic secretion. Its name breaks down: chole, bile; cysto, gallbladder; kinin, movement. It reflects its core job, stimulating the gallbladder to contract and release bile for fat digestion. The name highlights bile movement, but also covers its broader role in coordinating digestion, like pancreatic enzyme release and slowing the stomach to pace nutrient breakdown. Need more on its signaling?
Okay. Tell me again, I didn't get your answer, please. And I have the same question about motilin. How does it... Yeah. Motilin, can't figure it out, to be fair.
No worries, let's clarify. Cholecystokinin, CCK, named from chole, bile; cysto, gallbladder; kinin, movement. It triggers gallbladder contraction for bile release, aiding fat digestion, and also slows gastric emptying and boosts pancreatic enzyme secretion. The name emphasizes bile movement but reflects its digestion coordination role. Motilin, named for motility, as it stimulates gut movement. Released in fasting, it drives migrating motor complexes, wave-like contractions clearing the small intestine of debris and bacteria. The name directly ties to its job, keeping the gut moving. Want more on their mechanisms?
Yes, please.
All right, let's dig into the mechanisms of cholecystokinin, CCK, and motilin. CCK is secreted by eye cells in the small intestine, mainly when fats and proteins are detected. It binds to CCK receptors on the gallbladder, causing it to contract and release bile, and on the pancreas, triggering enzyme secretion for digestion. It also acts on vagal nerves to slow gastric emptying, giving the intestine time to process nutrients.
I see. Okay. Okay. Let's talk a bit about interstitial cells of Sahal and smooth muscle functional syncytium, shall we?
Cool, let's hit it. Interstitial cells of Cajal, ICCs, are pacemaker cells in the GI tract, sitting between smooth muscle layers. They generate electrical slow waves, setting the rhythm for gut contractions. Smooth muscle cells in the muscularis externa, inner circular and outer longitudinal, contract in sync with these waves, driving peristalsis to move food. ICCs connect to smooth muscles via gap junctions, forming a functional syncytium, where cells act as a single unit, sharing electrical signals for coordinated contractions. This setup ensures smooth, wave-like gut motility. Want details on ICC signaling or syncytium structure?
That makes sense. And what are these gap junctions that allow electrical coupling?
Gap junctions are tiny channels connecting smooth muscle cells and interstitial cells of Cajal in the GI tract. Made of connexin proteins, they let ions and small molecules pass directly between cells, allowing electrical signals to spread fast. This creates electrical coupling, so cells fire together, syncing contractions for peristalsis. Think of them as tunnels for instant signal sharing, ensuring the gut's smooth muscle works as a unit. Need more on their role in motility?
No, it's okay.
All right, cool. What's the next thing you want to tackle?
I want to ask you about the enteric nervous system a bit. So we talked about the myoenteric plexus and the submucosal plexus. One has to do with secretion, the other has to do with motility. But I wonder how the name relates to their function.
The enteric nervous system, ENS, runs the gut with two key plexuses. The myenteric plexus, named for its location between muscularis externa layers, myo equal sign, muscle, controls motility. It drives peristalsis by coordinating smooth muscle contractions. The submucosal plexus, named for its spot in the submucosa, regulates secretion, like mucus or enzymes, and local blood flow. Names reflect their anatomical positions, not functions directly, but their locations tied to their roles. Myenteric for muscle movement, submucosal for mucosal secretions. Want more on ENS signaling?
Okay. Okay.
Cool.
And can I ask about a bit about excitation contraction coupling? And also, I didn't understand, to be honest, how myenteric and submucosal plexuses names show their function. So if we could briefly touch on that too.
All right, let's keep it tight. Excitation contraction coupling in GI smooth muscle. Electrical signals from interstitial cells of Cajal, or myenteric plexus, open voltage-gated calcium channels in smooth muscle cells. Calcium floods in, binds to calmodulin, activating myosin light chain kinase. This triggers actin-myosin binding, causing contraction for peristalsis. Myenteric and submucosal plexus names. Myenteric, myo equal sign, muscle, sits between muscle layers, so it controls motility, muscle contractions. Submucosal, in the submucosa, manages secretions, mucus, enzymes, and blood flow near the mucosa. Names reflect location, which aligns with function. Muscle for movement, submucosa for secretion. Clearer now? Want more on coupling or ENS?
That's good actually. Okay, and let's talk a bit about segmentation and peristalsis now.
Segmentation and peristalsis are gut motility patterns. Segmentation, rhythmic contractions of circular smooth muscle, mainly in the small intestine, mix and churn contents to enhance digestion and absorption. Peristalsis, coordinated waves of circular and longitudinal muscle contractions, driven by the myenteric plexus and interstitial cells of Cajal, propel food forward through the GI tract. Segmentation stirs, peristalsis moves. Need specifics on their control?
I see. Okay, time for some pathophysiology. Let's talk about Hirschsprung's disease, and let's talk about absence of myenteric plexus. Wow.
Hirschsprung's disease is a congenital condition where the myenteric and often submucosal plexus is absent in parts of the colon, usually the distal end. Without these enteric neurons, affected segments can't coordinate peristalsis, leading to a functional obstruction. Stool backs up, causing constipation, megacolon, or even enterocolitis if untreated. It's caused by neural crest cell migration failure during fetal development. Symptoms include newborn failure to pass meconium, chronic constipation, or abdominal distension. Treatment often involves surgery to remove the aganglionic segment. Want details on diagnosis or complications?
Okay, so wait a sec. No, that makes sense, to be honest. And how do we so myenteric plexus is not there, so we just remove that section?
The myenteric plexus, and often submucosal, is missing in a colon segment, so that part can't contract or move stool. Surgery, like a pull-through procedure, removes the aganglionic, non-working section and connects healthy colon to the anus, restoring normal motility. Sometimes a colostomy is done first if the situation's urgent. Need more on the surgery or what causes the plexus absence?
Guys, we're doing a 2-minute break.
Sounds good, dude. Take a quick breather, and I'm here when you're ready to jump back in.
Okay, back to work, guys.
Yo, let's do this. What's next on the list? Ready to pick up where we left off or got something new?
Okay.
All right.
Let's continue, yeah. So, let's talk a bit about the process of swallowing. So,
Swallowing's a slick process, split into 3 phases. Oral phase, voluntary, tongue pushes food bolus to the pharynx. Pharyngeal phase, involuntary, triggered by bolus hitting sensors. Epiglottis closes, upper esophageal sphincter opens, bolus moves to esophagus. Esophageal phase, peristalsis, driven by enteric nerves, propels bolus through lower esophageal sphincter into stomach. Smooth muscle and myenteric plexus keep it coordinated. Need more on neural control or problems like dysphagia?
I want to talk about the pharyngeal phase. So, we have impulses traveling to the medulla oblongata and the pons in the central nervous system, basically, for the muscular contractions. So cool. Which is so obvious, but it's so cool.
Yeah, the pharyngeal phase is wild. It's involuntary and kicks off when the food bolus hits pharyngeal sensors. Sensory impulses zip to the swallowing center in the medulla oblongata and pons via cranial nerves like V, IX, X.
Okay,
medulla-
so, and we also, I want to talk, we have a soft palate and uvula blocking the nasopharynx. What are these words?
All right, let's clear it up. During the pharyngeal phase of swallowing, the soft palate, a flexible muscle flap at the back of the mouth, and uvula, that dangly bit hanging from it, lift to block the nasopharynx. This seals off the nasal cavity, preventing food or liquid from shooting up your nose. Soft palate, equal sign velum. Nasopharynx, upper throat behind the nose. It's a simple but slick move to keep swallowing smooth and safe. Want more on how they coordinate or issues if they fail?
That's okay, I guess. And in the esophageal phase, we have the peristaltis waves. We talked about them. But guys, I think we have another podcast on this. You can go check it out. Okay, what is achalasia?
Nice plug for the podcast. Achalasia is a disorder where the lower esophageal sphincter, LES, fails to relax during swallowing, and esophageal peristalsis is weak or absent.
And why would that happen?
Achalasia happens when nerves in the esophagus, especially the myenteric plexus, get damaged or degraded. This impairs peristalsis and stops the lower esophageal sphincter from relaxing. Causes aren't fully pinned down, but possibilities include autoimmune attacks, body mistakenly targets nerve cells, viral infections like herpes simplex triggering nerve damage, or genetic factors in rare cases. The result is food and liquid get stuck, leading to dysphagia, chest pain, or regurgitation. Need more on symptoms or treatments?
Okay. So
All right.
I want to ask you about the motor functions of the stomach a bit. So, what's the fundus? The fundus, they relax. And I don't understand this achalasia. Who causes this contraction? And tell me about, sorry guys, I'm just throwing arbitrary words, but if that's any good, they're as arbitrary for me too. Propulsion, retropulsion, what's all this?
No sweat. Let's sort it out efficiently. Stomach motor functions. The stomach mixes, stores, and moves food. The fundus.
Sorry guys, but this is, you can hear the beep. I don't like it. Dude, can you repeat exactly what you just said?
All right, here it is again, tight and clear. Stomach motor functions, mixes, stores, moves food. Fundus, upper, dome-like, lax reservoir. Holds food, vents gas, relaxes via vagal nerves to ease pressure. Propulsion, forward
Why
contractions
is he making such noises? It's so annoying. Hey, remember, keep things concise, use the least amount of words to get your point across, and be as effective and efficient as possible. Having said that, can you repeat what you just said in a few sentences?
Stomach motor functions, mixes, stores, moves food. Fundies, lax, upper reservoir, relaxes via vagal nerves, holds food, vents gas. Propulsion, body antrum contractions push chyme to pylorus. Retropulsion, antrum contractions mix and grind chyme backward. Achalasia, lower esophageal sphincter stays tight. Poor peristalsis from myoteric nerve damage. Autoimmune, viral, genetic. More details?
What is so? Retropulsion is food forced back for further mixing.
Yep. Retropulsion
And
is when
propulsion is?
propulsion, stomach body and antrum contractions push chyme forward toward the pylorus. Need more?
And then fundus?
Fundies, lax, upper stomach dome, stores food, vents gas, relaxes via vagal nerves. More?
What's the fundus? I don't understand.
Fundies, top, rounded part of stomach, acts like a stretchy pouch to hold food and gas, relaxing via vagal nerves to prevent pressure buildup. Want details on its role or nerves?
I guess I will never know what it is.
Haha, nah, let's nail it. Fundies is the stomach's top curved pocket. It's like a floppy balloon that holds food and burps out gas, stretching without squeezing thanks to vagal nerve signals. Clear now?
Kind of better now, yeah. Okay, so let me ask you about. Let's go back to another topic, and let me ask you a bit about. Sorry, guys, I'm just keeping up with my notes here.
No worries. Take your time.
I want to ask you about antimicrobial resistance rates.
Antimicrobial resistance, AMR, rates are rising globally. In the US, over 2.8 million AMR infections occur yearly, with 6 key hospital-onset bacterial infections up 20% during COVID, staying high in 2022. Globally, AMR killed 1.27 million in 2019, linked to 5 million deaths. By 2050, forecasts predict 39 million AMR deaths, with 169 million associated deaths, hitting South Asia and Sub-Saharan Africa hardest. Resistance to last resort antibiotics could double by 2035. Need specifics on pathogens or trends?
So what's prevention of... Okay, so how do we prevent UTI, and what's catheter-associated UTI?
Preventing UTIs. Stay hydrated. Urinate often. Wipe front to back. Avoid irritants, like harsh soaps. And for women, pee after sex. Cranberry products may help. For recurrent cases, doctors might use low-dose antibiotics or post-sex prophylaxis. Catheter-associated UTIs, CAUTIs. Infections from urinary catheters, common in hospitals. Bacteria climb the catheter, causing infection. Prevention, use catheters only when needed. Remove ASAP. Maintain sterile insertion, and keep drainage bags below bladder level. Need more on CAUTI risks or treatment?
To be honest, I didn't understand your answer. I'm trying my best. If you haven't noticed, guys, sometimes the podcasts are a bit. Yeah, tell me again, dude, in a sentence. So, yeah, sometimes the podcasts are tiring, but this is how it is to be a student. Anyway, sorry. Yeah, tell me again in a sentence.
Prevent UTIs with hydration, frequent urination, proper hygiene. Catheter-associated UTIs caused by bacteria on catheters are prevented by sterile insertion, minimal use, and quick removal. More details?
That's okay. So what's the difference between relapse and recurrence?
Relapse, same UTI infection returns after incomplete treatment, usually within 2 weeks. Recurrence, new UTI, often different bacteria, typically after 2 weeks or more. Want treatment differences?
I see. So relapse is the same kind of one.
Yep. Relapse is the same UTI bacteria coming back, usually because treatment didn't fully clear it. Need more on why it happens?
No, it's okay. Okay. So let's go back to our other topic. So we're talking about gastric emptying.
Cool. Back to gastric emptying. It's how the stomach pushes chyme into the small intestine, controlled by the pyloric sphincter, hormones like CCK, and vagal nerves. What's the angle you want to hit? Delay issues, regulation, or something else?
Why don't we talk a bit about dumping syndrome and gastroparesis?
Dumping syndrome. Stomach empties chyme too fast into small intestine, often after gastric surgery. Early dumping, 30-60 minute post-meal, causes nausea, bloating, diarrhea from fluid shifts. Late dumping, 1 to 3 hours, brings hyposapevia from insulin spikes. Gastroparesis, delayed gastric emptying due to nerve muscle dysfunction, often from diabetes or vagal nerve damage. Symptoms, nausea, vomiting, fullness, undigested food. Dumping's too quick. Gastroparesis is too slow. Need treatment or causes?
I see, so they're the opposite.
Exactly. Dumping syndrome is the stomach emptying too fast. Gastroparesis is too slow. Want more on symptoms or fixes?
Why don't we talk a bit about nutrient absorption in the small intestine? So we have, and tell me what plicae circularis are, mucosal villi and microvilli.
Nutrient absorption in the small intestine is maxed out by its huge surface area. Plicae circularis, permanent circular folds of mucosa and submucosa, like ridges, boosting surface area and slowing chyme for better mixing. Villi, finger-like mucosal projections, covered in absorptive cells, increasing area further. Microvilli, tiny, brush-like extensions on villi cells' surfaces, forming the brush border, packed with enzymes and transporters for final digestion and nutrient uptake. Together, they amplify absorption efficiency for carbs, proteins, fats, vitamins, and minerals. Need specifics on nutrient pathways?
That's okay. Why don't we talk a bit about propulsive peristaltic reflexes then?
Propulsive peristaltic reflexes drive food through the gut, triggered by chyme stretching the intestinal wall. Sensory neurons in the myoteric plexus signal circular muscle to contract behind the bolus and longitudinal muscle to relax ahead, creating a wave-like push. Interstitial cells of Kajal set the rhythm. This reflex, wired by the enteric nervous system, ensures one-way movement for digestion and waste. Want more on neural control?
Yes.
Propulsive peristaltic reflexes are controlled by the enteric nervous system, mainly the myenteric plexus. Chyme stretches the gut wall, activating sensory neurons that signal motor neurons via the plexus. This triggers circular muscle contraction behind the bolus and longitudinal muscle relaxation ahead, pushing it forward. Interstitial cells of Cajal generate electrical slow waves for rhythm. Vagal and pelvic nerves add input, but the ENS runs the show locally. Need details on misfires like in ileus?
And then the final stages, basically the large intestine is mainly water reabsorption, right? And what do we mean by commensal microbiome?
Yep, the large intestine mainly reabsorbs water, turning liquid chyme into solid feces, while also absorbing electrolytes like sodium. Commensal microbiome, trillions of gut bacteria, mostly in the large intestine, that live symbiotically with us. They ferment undigested carbs, produce vitamins like K and B, regulate immunity, and crowd out pathogens. Think of them as helpful gut roommates. Need more on their roles or water absorption mechanics?
That's good. And lastly, I wanna some help with hostral bulges. What does that mean?
I'm guessing you meant hosteral bulges, but it sounds like you might be referring to osteal bulges
No,
or something
hostral.
similar.
Haustral bulges, and hostral churning. Dude, I honestly, this is such a hard chapter. It's like I'm speaking a different language.
No worries, dude. Hostral bulges and hostral churning can feel like alien terms. Here's the deal, super concise. Hostral bulges are sac-like pouches, hostra, in the colon wall, formed by Taeniae coli, longitudinal muscle bands, and circular muscle contractions. They increase surface area for water absorption. Hostral churning, slow, segmental contractions of hostra, moving chyme between pouches to mix and absorb water, triggered by chyme distension. It's like the colon's gentle kneading to dry out poop. Need a simpler breakdown or more on how it works?
I don't get what this is.
Alright, let's make it crystal clear. Hostral bulges. The colon's wall has pouchy sacs called hostra, like little balloons, made by tight muscle bands and contractions. They hold chyme to suck out water. Hostral churning. These pouches gently squeeze and shift chyme back and forth, mixing it to absorb more water and form poop. Picture a slow, squishy massage in the colon. Got it now? Want a visual or more?
So good. Yeah, to be honest, can you tell me again in a few words? And then I want us to talk about the defecation reflex.
Hostral bulges. Colon's pouchy sacs for water absorption. Hostral churning. Pouches mix chyme via slow contractions. Defecation reflex. Rectum fills with poop. Stretching triggers sensory nerves, signaling spinal cord. Internal anal sphincter relaxes involuntarily.
Okay, and now the defecation reflex. What's going on? We have internal and external anal sphincter, or what? And how does the parasympathetic sympathetic play part here?
Defecation reflex. Poop fills rectum, stretching it. Sensory nerves signal spinal cord, S2, S4. Internal anal sphincter. Involuntary, smooth muscle relaxes via parasympathetic nerves, pelvic splanchnic. External anal sphincter. Voluntary, skeletal muscle, stays closed until you choose to relax it. Parasympathetic drives reflex, promoting relaxation and rectal contraction. Sympathetic nerves, lumbar splanchnic, can inhibit. Tightening sphincters to delay poop. It's a balance. Parasympathetic pushes go, sympathetic says hold. Need more on nerve pathways?
Oh, that makes sense. Alrighty. Perfect. Guys, thank you for watching. I didn't understand shit at points. Other points I kind of understand some things. Thank you. I will talk at the next